going to talk about ESMO guidelines for carcinoma of unknown primary. Now, thanks to the authors. And so, what is carcinoma of unknown primary? It's where you don't know where the cancer is from. It accounts for 3 to 5% of all the malignancies. Okay. And uh, how do you approach it? Well, so you can, do a pathology evaluation and see what type it is of like cancer. Is it an adenoma? Is it a squamous? Is it a neuroendocrine? Or is it a poorly differentiated cancer? Okay, so this is very important, and then based on that, you can then order an IHC where the immunohistochemistry, uh, and you should check for PSA to rule out prostate, and then you should check for PR in females to rule out breast. If you get lucky, it may show. And then you have the CK7, CK20 algorithm. And then you have the PAX8 and WT1 algorithm, which is specific for ovarian in females, or you can have PAX8 in males with RCC positivity. So your IHC is going to guide you. Well, now here you can see cytokeratins. We'll discuss PSA, ERPR, and napsin, thyroglobulin, neuron-specific enolase chromogranular synaptophysin, which a pathologist will report as neuroendocrine carcinoma of unknown primary, and then it's check for desmin, vimentin to see if it's soft tissue, unknown primary. Look for S100, which will be positive in melanoma. Look for AFP, HCG, PLAB, which is either germ cell thing. So CK7, CK20. So look at the body like that, 7 and 20. Both are positive in the midline. 20 would be positive in colorectal and Merkel. Okay, 7 would be positive and 20 would be negative in the anything above the diaphragm where the lung, breast, thyroid, endometrial, cervical, and pancreatic. So basically, lung, breast, thyroid, and endometrial is below, so that's an exception to the rule. Okay, endometrium will be below here, and cholangio and pancreatic can do 7 positive 20 positive mostly if it's that, then if it's this one diaphragm and then there's another pelvic diaphragm, so you can consider bladder or urothelium, which both CK7 and CK20 close to diaphragm, both the breathing and diaphragm. Well, now once you've finalized that, then you go into all your basics, take a history, you make sure the CT scan is done, do a breast MRI, do alpha fetoprotein, make sure you didn't miss out anything. And then how do you manage this according to these guidelines? Well, if it's a neuroendocrine carcinoma of unknown primary, you do platinum etoposide. If it's a well differentiated carcinoma with neuroendocrine, then you can do a somatostatin route. If it's a peritoneal adenocarcinoma of serous papillary, you can treat it like ovary where you do an optimal surgical debulking and HIPEC if indicated. With squamous cell carcinoma involving non-supraclavicular, you can possibly consider going in for neck dissection if you're trying for cure in head, if you suspect head and neck. If it's carcinoma primary with colorectal IHC, you know, then you give the metastatic colorectal for FOX6 regimen. And if it's a single metastatic deposit, then you could do, oligometastatic disease and you manage it like that. So you do your workup and then you also check for PDL1 if you wish. And you manage the patient with their basic regimens. So that's a quick overview. Carcinoma unknown primary in 5 minutes.